Today, I'm chatting with Dr. Josephine Etowa. She's an absolute legend who's improving the health outcomes of African, Caribbean, and Black women globally.
I like to use that concept of ACB because it constantly reminds me that I cannot leave anyone behind. I do understand those needs. I have those needs myself.
Come, let's meet her and hear how she's transforming lives.
Tell us your story. How did Dr. Etowa come about?
Great question. Thank you. So, yes, I'm a full professor in the School of Nursing at the University of Ottawa's Faculty of Health Sciences and Canada Research Chair Tier 1 in advancing Black women's health in Canada. As a Black woman, a nurse, and a researcher, I have seen firsthand the deep inequities that Black women face when it comes to their health in Canada. Working in at the bedside as a nurse, that's part of what drove me to go back to grad school and to want to be part of the solution, to contribute to this work. And I have been at the University of Ottawa for the past 16 years. I've held a research chair in public health nursing. I have also held a research chair over the last 7 years, looking 4 years, specifically looking at Black women and HIV in Ontario. That research chair was funded by the Ontario HIV Treatment Network, OHTN, before moving into this national chair, the Canada Research Chair Tier 1. In all of this, my work is deeply rooted in advancing the health and well-being of Black communities, especially Black women, whose needs have been historically overlooked or inadequately addressed in the healthcare system. And the other thing that drives my work is that I believe in the power of community-led change. Through research, education, and policy advocacy, I believe in pushing the healthcare system to recognize and respond to the unique realities of Black people and Black women in Canada. And we have been resilient for generations as Black people, but now it's time we also experience justice, dignity, and full access to health and well-being. And that's what our work does at the Co-Create Lab. That is the collaborative critical research for equity and transformation in health at the University of Ottawa Faculty of Health Sciences. Actually, I'm the founding president, the inaugural president of the Canadians of African Descent Health Organization, and currently also leads the organization. It's been an interesting work, and CADO, actually that organization, a community organization, came about as a result of the people here in Ottawa looking for a way to use the data we generate, the evidence we've been generating, to continue to do their advocacy work. And so it's part of an advocacy organization created out of the need to use the data that we're now generating to inform changes in both practice and policy.
In your research, what are some of the key challenges that you're seeing when it comes to the health of ACB, African, Caribbean, and Black women?
You know, Black women in Canada face a range of intersecting challenges, whether it's related to sexual health, mental health, the stigma that surrounds both sexual health and mental health, whether it's related to just the whole reproductive health, fibroids, and others. These challenges are, however, rooted in systemic inequities, cultural barriers, and historical marginalization that the community have faced. So let's talk, when we talk about sexual health, the reality that Black women in Canada are disproportionately affected by HIV and other sexually transmitted. It still exists. We talk about how Black people continue to be disproportionately affected by HIV. We've been saying this, even though Black people make up only about 5% of the country's population, they make up 25% of new cases or new diagnoses of this disease. And even when we have prophylaxis, preventive measures, they continue to be disproportionately impacted by this disease. So this is happening despite sexual health education services that are not often designed with ACB people in mind. So there's a lot of stigma in the ACB communities around discussing sexual health. Unfortunately, many Black women face judgment or bias when they try to assess care. All of this creates a barrier to early diagnosis, prevention, and treatment when we're talking about that. The other issue is around mental health. Mental health is where the challenges are profound. So many Black women carry the weight of multiple burdens, whether it's racism, sexism, financial pressure, family responsibility, and all of this takes a toll on the mental health of Black women. Yet the stigma around mental health can be intense. We are often expected to be strong no matter what. The myth of the strong Black woman. And that can make it really hard to admit when one is struggling or even to reach out for help. So on top of that, finding mental health professionals who understand the lived experiences of Black women, who look like them and can relate culturally is still far too difficult. And so stigma plays a big role in all of this, whether it is the internalized shame and societal stereotypes or systemic discrimination within the healthcare system. Black women are constantly navigating spaces that weren't built for them. It is exhausting and it can discourage them from actually accessing the care they need and deserve. And so, in addition to dealing with these issues, whether it's, and I also mentioned fibroids, that we've all heard how many Black women are affected by fibroids. So combating these challenges requires a multifaceted, community-informed approach that prioritizes equity, dignity, and justice. And so when we think about these challenges Black women face, first, we need more culturally appropriate and community-based healthcare services. Black women deserve to be seen, to be heard, and to be cared for by providers who understand the context of their life. What that means is that we need to hire more Black professionals and train more others in anti-racism and cultural competence and humility. So we know that by centering the voices of Black women and experiences of Black women, we can move forward as a nation, as a more inclusive and responsive healthcare system. So I really, when you talk about these challenges, I really think that we need to be more open in our communities in terms of talking about both sexual and mental health. And that begins with education. That's why we have programs in Co-Create Lab. We have the critical health and racial literacy program that we have actually two, one community facing and one system facing that trains healthcare providers on how they can work more effectively across racial and cultural boundaries to provide care for Black women. And then the community-facing intervention includes the training of peer equity navigators, whose focus is on the community doing outreach to reach out to Black women to educate them about the health needs, about how to navigate the churches, how to navigate the healthcare system. This education happens through churches, through schools, through any media platform that we find that we can use to hopefully help Black women normalize the normalize health seeking and behaviors to be able to look for resources when they need it without feeling like that makes them look weak. Again, when we talk about challenges that Black women face, we cannot talk about them without addressing the broader social factors that shape those things, like housing, income, education, the social determinant. Health doesn't exist in a vacuum. We have to confront the root causes of health inequities. if we truly need to address these challenges that Black women face.
I've always been concerned about that stigma around a lot of these health issues that you talk about, around sexual health, mental health, for sure. Because in our community, we don't really talk about it as much.
Mm-hmm.
And but do you find that that's changing? Because from my perspective, I think there's still that stigma. And where do we even start? Because we can speak about it at school or through these programs, but when we go home, if we're not talking about it amongst ourselves,
Mm-hmm.
that's I think. What do you think? It's I think this is that perhaps that's where it should be starting. How do we ensure that that starts among families and in the home?
Absolutely. Yeah, you are right about that, that we need to have these conversations in our families, in our homes, in our churches. And that's part of why we're training the peer equity navigators to go back and make this happen. We're also in other projects looking at intergenerational discussions where families can have this discussion, mothers and children, auntie having that discussion with their niece and nephews, and these kinds of conversation happening across generation. Older family members having it with younger family members. So we need to have that conversation. Is the issue of stigma changing? I would say yes, it's changing because we are more aware of it. We're talking about it. So increasing the visibility is part of what creates that change. So increased visibility is happening. We continue to provide this education, and we're hoping that hopefully that will continue to see more change that translates into better health outcomes in the future.
And I'm just curious, we talk about that intergenerational issue. Are you finding a difference between, let's say, for lack of a better word, the kind of older generation with the newer generation that is coming? Did you find, based on your research or your observation, do you find a difference there?
Yes, there are differences. There are areas of commonalities, right? So, because when you talk about even differences among ACB people or the length of time they came into Canada and all of that, while ACB people, or let's say ACB, I'm using ACB and Black interchangeably, African, Caribbean, and other Black, literally referring to people who have migrated from Black people who have migrated from Africa, or Black people that have migrated from the Caribbean. And then the B stands for Black people that have lived in Canada and the Western world for multiple generations. All of these Black people often share common experiences related to anti-Black racism, cultural invisibility, and systemic barriers in healthcare. They share in their health concerns, their lived experiences, and healthcare needs are not necessarily identical because these differences are shaped by whether it's migration pattern, the length of time you've been dealing with racism, cultural background, language, socioeconomic status, and religious beliefs. And like you say, generational status. All of this influence how we engage in health systems and how we engage in health. So how our health is impacted. So there are areas of common experience, but there are also differences. And so, for example, all across the ACB communities, whether it's young or old, women will face systemic issues, racism in healthcare setting when they go. This leads to misdiagnosis, inadequate care, or mistrust. They face the issue of the underrepresentation of health research, which then leads to lack of data to inform culturally responsive health policies and even healthcare. They all face the stigma we're talking about that is reinforced by both the community and the societal attitude. And so, what does this lead to? Higher prevalence of chronic diseases like high blood pressure, diabetes, uterine fibroids, conditions that often go untreated or even undiagnosed because of those issues. But are some of our concerns um, the same? No, because even though we all face these other common issues, there are also factors that contribute to the ways in which we experience or respond to these disease conditions. So, for example, the recently migrated African woman may delay seeking care for fibroids due to the unfamiliarity with the healthcare system or language barrier if they come from the Francophone country and may not want to go. That is not the same case for a woman, a recently migrated Black woman from the Caribbean who may avoid discussing mental health due to the stigma in her church about mental health. Or for the Black Canadian, the Canadian-born Black woman who might recognize depressive symptoms, but the distrust of the healthcare system due to her past experiences with discrimination may prevent her from seeking care. So do you see that they may not, their condition may be affected by the poor engagement with the system, but the reason behind it is different. And this is important because if we want to design interventions, whether it's research or policies that treat Black women, we cannot treat them as a homogeneous group because then we will miss these nuances that clearly shows that one size does not fit all. It won't work. That kind of approach won't work. And so we need to take into consideration the cultural nuances and use an intersectional approach that recognizes both the shared and distinct realities of Black women.
How do because we can ensure that Black women, that ACB women, they have the information that they need. But how do we empower them? Because some of them, they're maybe a little bit timid to say, they may go to their doctor or if they're comfortable with their doctor and receive some information. Sometimes, how do we empower them to ask those hard questions, even of their doctors?
Education, I believe. So empowering African, Caribbean, and Black women to play an integral role in their own health and well-being requires more than individual motivation. It demands structural support, community-based approaches, and a culturally responsive system that affirms their identities, experiences, and even leadership. If they see themselves reflected in leadership, if Black women feel that they are supported, they are informed, they are centered in their own care, then the system, they would feel that they're part of the system. They see themselves reflected in leadership. They are invited to the table, or they're part of the leadership that's inviting others to the table. I think that kind of structural support is needed for them to build even the individual motivation that our educational offerings or training can provide for them. And so we really need to think about that, because empowerment, it is not just a luxury that some people can have. It is more of a public health imperative that needs to come from within the system as well, the structure supporting that to happen. I just want to add that nothing for us without us. Again, nothing for Black women without Black women at the center of it would be empowering. So they need to be part of every aspect of programming that is targeting them.
Yeah, I completely agree, because oftentimes we develop policies without even speaking to the people that they're going to impact, or the people that the policies are for. So it's really important that and for example, if the policymakers don't reach out to us, we need to go and say, you know what, we need to be part of this conversation. We need to be at the table.
Absolutely.
Are you seeing any improvements in these areas over the years that you've been doing research? And I think you're also doing a longitudinal study, I understand.
We're doing different studies. I'm part of other teams that are doing different kinds of study. Yes, but to answer that question, yes, we are seeing incremental progress, I would say, and it's encouraging because we still have a long ways to go. Where are we seeing improvement? There's growing awareness now about the unique health challenges that Black women face. Things like the higher rates of hypertension, HIV, uterine fibroid, mental health, stigma. For years, these issues were under research and under address. So that's progress. that we're actually now paying attention. So the progress here is the increased visibility. More researchers, more health organizations are collecting race-based data, especially after the COVID-19 exposed the deep racial health disparities or inequities that exist. We're now seeing a rise in Black-led organizations and community-driven programs that are meeting people where they are and offering culturally safe and accessible care. We have programs like the Taibo Health Center in Toronto. We have other programs, again, like the Canadians of African Descent Health Organization here in Ottawa that are doing this work to raise awareness, like the Co-Create Lab at the University of Ottawa that is training parents all across Ontario to educate Black women about HIV and other issues that we're addressing. So there is progress, but we still have a lot to do. There are also policy level shifts that are happening. So some provincial health systems are now beginning to recognize anti-Black racism as a health determinant, and they are investing in equity initiative. For example, we're seeing leadership from even scholars in academic institutions. I know my colleague Priscilla Bokia is doing work around Black mental health for perinatal women, so maternal health. In Co-Create Lab, we're doing the same thing to move the needle around these maternal mental health and social determinants. But you know what, at the same time, the challenges remain serious. Many programs are underfunded. There is still a lack of culturally competent healthcare providers. We were training, but we still have a long ways to go. The critical health and racial literacy program we developed at the Co-Create Lab that's educating providers. We've reached over 500. Our target was for the test period to do 100. 500, over 500 have completed it. And so we trust that the healthcare system would continue to advance in terms of doing more to create a system that Black women can trust, because right now, trust in the healthcare system among Black women is low because of the real lived experiences of racism and neglect. And so the most helpful sign in terms of what is happening is that Black women are leading some of this change. As healthcare professionals, as researchers like myself, as community advocate, we are taking part in this work. We're not just part of the conversation anymore. We're helping to shape it. So yes, there is progress, but the focus now is making sure that this progress is sustainable, that there's a system-wide change that is driven by Black voices.
Yes, yes, sustainability is immensely important. And I was also wondering, we've got all these incredible programs that are out there.
Mhm.
However, how do we perhaps collaborate with others to build awareness around those programs, to make sure that as many people know about them as possible,
Mhm.
and not solely the people that work in those areas, but others know about these programs and can benefit from them.
Collaboration is key. And that's why we talk about doing community-based participatory research approach, where collaboration is a key requirement of doing that work and looking out for others who are interested in this work and using all of the social media platforms we have and other communication tools to reach out to partners in different disciplines, whether it's in policy, in practice setting, in research setting, in educational programs, so that we can actually work together to advance this work.
What does positive change look like to you? And what would you like to see? What are your hopes and dreams for the ACB community, let's say, within the next 3 to 5 years and beyond?
Okay, again, good question. That's a big one. So to me, positive change and success means more than just reducing statistics. It is about building a healthcare system where Black women or Black people are seen, heard, and treated with the respect and dignity they deserve. What does that look like? Walking into a clinic and knowing your pain will be taken seriously. It means access to culturally safe care, from mental health support to maternal child care, that is provided by people who understand your lived experience. It's about no longer feeling invisible in research or policy, so we can see data that speaks to our issue. We can be able to see how this health condition, whether it's fibroids or other things affecting Black women, we can have data to support exactly how we're affected differently. We're also talking about Black-led health organizations. So we need more Black therapists, doulas, doctors, increased representation at every level of decision making. That's what success looks like. I want to see health outcomes improve where there are fewer cases of high blood pressure, there are fewer cases of people living with HIV, there are more support for uterine fibroids or better mental health resources for Black women and girls. And in the next 3 to 5 years, I hope we will all see more targeted health initiatives that are backed by real funding, more Black women in leadership roles, and greater public recognition of the health issues we as Black women face, not just during crisis, but all the time. And ultimately, I want to see a future where Black women don't have to fight to be cared for. We just will be cared for. That's the kind of transformation that we at Co-Create Lab are working towards.